Lewis's Medical Surgical Nursing, 11th edition, Chapter 46, Acute Kidney Injury and Chronic Kidney Disease. Kidney failure, also called renal failure, is the partial or complete impairment of kidney function. It results in an inability to excrete metabolic waste products and water. Kidney failure contributes to problems with all body systems. All patients have problems with fluid, electrolyte, and acid-base imbalance. Adhering to dietary therapies and the treatment plan can be challenging. The patient must deal with changes in lifestyle, occupation, family relationships, and self-image that can lead to withdrawal and depression. The patient grieves the loss of kidney function and independence. Kidney failure is classified as acute or chronic. Acute kidney injury, AKI, has a rapid onset. Chronic kidney disease, CKD, is gradual with a progressive decline in kidney function. Acute kidney injury. AKI is the term used to encompass the entire scope of the syndrome, ranging from a slight deterioration in kidney function to severe impairment. AKI is characterized by a rapid loss of kidney function. This loss is accompanied by a rise in serum creatinine and/or a reduction in urine output. AKI can develop over hours or days with progressive elevations of blood urea nitrogen, BUN, creatinine, and potassium, with or without a reduction in urine output. The severity of dysfunction can range from a small increase in serum creatinine or reduction in urine output to the development of azotemia, an accumulation of nitrogenous waste products, urea nitrogen, creatinine, in the blood. Although AKI is potentially reversible, it has a high mortality rate. AKI usually affects people with other life-threatening conditions. AKI often follows severe, prolonged hypotension, hypovolemia, or exposure to a nephrotoxic agent. Hospitalized patients develop AKI at a high rate, 1 in 5, and have a high mortality rate. When AKI develops in patients in intensive care units, ICU, the mortality rate can be as high as 70 to 80%. Etiology and pathophysiology. The causes of AKI are multiple and complex. We categorize them as prerenal, intrarenal or intrinsic, and postrenal causes. Table 46.2 and figure 46.1. Prerenal. Prerenal causes of AKI are factors that reduce systemic circulation, causing a reduction in renal blood flow. The decrease in blood flow leads to decreased glomerular perfusion and filtration of the kidneys. It is important to distinguish prerenal oliguria from the oliguria of intrarenal AKI. In prerenal oliguria, there is no damage to the kidney tissue, parenchyma. The oliguria is caused by a decrease in circulating blood volume, e.g., severe dehydration, heart failure, decreased cardiac output. Prerenal oliguria is readily reversible with appropriate treatment. With a decrease in circulating blood volume, autoregulatory mechanisms that increase angiotensin II, aldosterone, norepinephrine, and antidiuretic hormone try to preserve blood flow to essential organs. Prerenal azotemia results in a reduction in sodium excretion, less than 20 milliequivalents per liter, increased sodium and water retention, and decreased urine output. Prerenal conditions contribute to intrarenal AKI. If decreased perfusion persists for an extended time, the kidneys lose their ability to compensate and damage to kidney parenchyma occurs. Intrarenal damage. Intrarenal. Intrarenal causes of AKI, table 46.2, include conditions that cause direct damage to the kidney tissue, resulting in impaired nephron function. The damage from intrarenal causes usually results from prolonged ischemia, nephrotoxins, e.g. aminoglycoside, antibiotics, contrast media, hemoglobin released from hemolyzed red blood cells, RBCs, or myoglobin released from necrotic muscle cells. Nephrotoxins can cause obstruction of intrarenal structures by crystallizing or causing damage to the epithelial cells of the tubules. Hemoglobin and myoglobin can block the tubules and cause renal vasoconstriction. Kidney diseases such as acute glomerulonephritis and systemic lupus may also cause AKI. Acute tubular necrosis, ATN, is the most common intrarenal cause of AKI in hospitalized patients. It is primarily the result of ischemia, nephrotoxins, or sepsis. Ischemic and nephrotoxic ATN is responsible for 90% of intrarenal AKI cases. Severe kidney ischemia causes a disruption in the basement membrane and patchy destruction of the tubular epithelium. Nephrotoxic agents cause necrosis of tubular epithelial cells, which slough off and plug the tubules. Other risks associated with developing ATN while in the hospital include major surgery, shock, blood transfusion reaction, muscle injury from trauma, and prolonged hypotension. ATN is potentially reversible if the basement membrane is not destroyed and the tubular epithelium regenerates. Postrenal. Postrenal causes of AKI involve mechanical obstruction in the outflow of urine. With the flow of urine obstructed, urine refluxes into the renal pelvis, impairing kidney function. The most common postrenal causes are benign prostatic hyperplasia, BPH, prostate cancer, stones, trauma, and extrarenal tumors. Bilateral ureteral obstruction leads to hydronephrosis, kidney dilation, increase in hydrostatic pressure, and tubular blockage, resulting in a progressive decline in kidney function. If bilateral obstruction is relieved within 48 hours of onset, complete recovery is likely. Prolonged obstruction can lead to tubular atrophy and irreversible kidney fibrosis. Postrenal causes of AKI account for less than 10% of AKI cases. Clinical manifestations. Prerenal and postrenal AKI that has not caused intrarenal damage usually resolves quickly with treatment. When parenchymal damage occurs due to either prerenal or postrenal causes, or when parenchymal damage occurs directly, as with intrarenal causes, AKI has a prolonged course. Clinically, AKI may progress through phases: oliguric, diuretic, and recovery. When a patient does not recover from AKI, CKD may develop. The Rifle classification describes the stage of AKI, table 46.3. Risk, the first stage of AKI, is followed by injury, which is the second stage. Then, AKI increases in severity to the last, or third stage, failure. The two outcome variables are loss and end-stage renal disease. Oliguric phase. The most common manifestations of AKI are discussed in this section. Urinary changes. The most common initial manifestation of AKI is oliguria, a reduction in urine output to less than 400 milliliters per day. Oliguria usually occurs within 1 to 7 days of the injury to the kidneys. If the cause is ischemia, oliguria often occurs within 24 hours. When nephrotoxic drugs are involved, the onset may be delayed for as long as 1 week. This phase lasts on average 10 to 14 days, but can last months in some cases. The longer the oliguric phase lasts, the poorer the prognosis for complete recovery of kidney function. Non-oliguric AKI has a urine output greater than 400 milliliters per day. About 50% of patients will be non-oliguric, making the initial diagnosis more difficult. While changes in urine output generally do not correspond to changes in glomerular filtration rate, GFR, they can be helpful in distinguishing the cause of AKI. For example, anuria, no urine output, is usually seen with urinary tract obstruction. Oliguria is often seen with pre-renal causes. Non-oliguric AKI occurs with acute interstitial nephritis and ATN. A urinalysis may show casts, RBCs, and white blood cells. Casts form from mucoprotein impressions of the necrotic renal tubular epithelial cells, which slough into the tubules. The specific gravity may be fixed at around 1.010, with urine osmolality at about 300 milliosmoles per kilogram. This is the same specific gravity and osmolality of plasma, thus reflecting tubular damage with a loss of concentrating ability by the kidney. Proteinuria may be present if AKI is related to glomerular membrane dysfunction. Fluid volume. Hypovolemia, volume depletion, has the potential to worsen all forms of AKI. Fluid replacement is often enough to treat many forms of AKI, especially pre-renal causes. When urine output decreases, fluid retention occurs. The severity of the manifestations depends on the extent of the fluid overload. In the case of reduced urine output, anuria and oliguria, the neck veins may become distended with a bounding pulse. Edema and hypertension may develop. Fluid overload can eventually lead to HF, pulmonary edema, and pericardial and pleural effusions. Metabolic acidosis. In the normal kidney, excess hydrogen ions are excreted to maintain a physiologic balance of the blood pH. Impaired kidneys cannot excrete hydrogen ions or the acid products of metabolism. Serum bicarbonate, HCO3, production decreases from defective reabsorption and regeneration of HCO3 ions. Serum HCO3 is depleted through buffering of acidic hydrogen ions and metabolic end products. The patient with severe acidosis may develop Kussmaul respirations, rapid deep respirations, to try to compensate by increasing CO2 exhalation. Sodium balance. Damaged tubules cannot conserve sodium. Urinary sodium excretion may increase, resulting in normal or below normal levels of serum sodium. Excess sodium intake is avoided because it can lead to volume expansion, hypertension, and HF. Uncontrolled hyponatremia, or water excess, can lead to cerebral edema. Potassium excess. The kidneys normally excrete 80% to 90% of the body's potassium. In AKI, the serum potassium level increases because the kidney's normal ability to excrete potassium is impaired. The risk for hyperkalemia increases if AKI is caused by massive tissue trauma because the damaged cells release potassium into the extracellular fluid. Bleeding and blood transfusions may cause cellular destruction, releasing more potassium into the ECF. Metabolic acidosis worsens hyperkalemia as hydrogen ions enter the cells, and potassium is driven out of the cells into the ECF. While patients with hyperkalemia are often asymptomatic, some may have weakness with severe hyperkalemia. Because cardiac muscle is intolerant of acute increases in potassium, emergency treatment of hyperkalemia is needed. Acute or rapid development of hyperkalemia may result in signs that are apparent on electrocardiogram (ECG). These changes include peaked T waves, widening of the QRS complex, and ST segment depression. Progressive changes in the ECG related to increasing potassium levels are shown in Figure 16.4. Hematologic disorders. Several hematologic disorders occur in patients with AKI. Hospital-acquired AKI often occurs in patients who have multi-organ failure. Leukocytosis is often present. The most common cause of death in AKI is infection. The most common sites of infection are the urinary and respiratory systems. Waste product accumulation. The kidneys are the primary excretory organs for urea, an end product of protein metabolism, and creatinine, an end product of endogenous muscle metabolism. Bun and serum creatinine levels are increased in kidney disease. An increased Bun level also can be caused by dehydration, corticosteroids, or catabolism resulting from infections, fever, severe injury, or GI bleeding. The best serum indicator of AKI is creatinine because it is not affected by other factors. Neurologic disorders. Neurologic changes can occur as the nitrogenous waste products accumulate in the brain and other nervous tissue. The manifestations can be as mild as fatigue and difficulty concentrating and escalate to seizures, stupor, and coma. Diuretic phase. During the diuretic phase of AKI, daily urine output is usually around 1 to 3 liters, but may reach 5 liters or more. The nephrons are still not fully functional even as urine output increases. The high urine volume is caused by osmotic diuresis from the high urea concentration in the glomerular filtrate and the inability of the tubules to concentrate the urine. In this phase, the kidneys have recovered their ability to excrete wastes but not to concentrate the urine. Hypovolemia and hypotension can occur from massive fluid losses. Patients who develop an oliguric phase will have greater diuresis as kidney function returns. Large losses of fluid and electrolytes require patient monitoring for hyponatremia, hypokalemia, and dehydration. The diuretic phase may last 1 to 3 weeks. Near the end of this phase, the patient's acid base, electrolyte, and waste product, Bun creatinine, values stabilize. Recovery phase. The recovery phase begins when the GFR increases, allowing the Bun and serum creatinine levels to decrease. Major improvements occur in the first 1 to 2 weeks of this phase. Kidney function may take up to 12 months to stabilize. The patient's overall health, severity of kidney injury, and number and type of complications influence the outcome of AKI. Some patients do not recover and progress to end-stage renal disease, ESRD. The older adult is less likely to have a complete recovery of kidney function. Patients who recover may achieve clinically normal kidney function but remain in an early stage of CKD. Diagnostic studies. A thorough history is essential for diagnosing the cause of AKI. Consider prerenal causes when there is a history of dehydration, hypotension, or blood loss. Suspect intrarenal causes if the patient has been exposed to potentially nephrotoxic drugs or contrast media used in a radiologic study. A history of changes in the urinary stream, stones, BPH, or bladder or prostate cancer suggests post-renal causes. Although changes in urine output and serum creatinine occur relatively late in the course of AKI, They are known diagnostic indicators. An increase in serum creatinine may not be evident until there is a loss of more than 50% of kidney function. The rate of increase in serum creatinine is important as a diagnostic indicator in determining the severity of injury. Urinalysis is an important diagnostic test. Urine sediment containing abundant cells, casts, or proteins suggests intrarenal disorders. The urine osmolality, sodium content, and specific gravity help in distinguishing the causes of AKI. Urine sediment may be normal in both pre-renal and post-renal AKI. In intrarenal problems, hematuria, pyuria, and crystals may be seen. Other testing may be needed. Table 46.4. A kidney ultrasound is often the first test done. It provides imaging without exposure to potentially nephrotoxic contrast agents. It is useful for evaluating for kidney disease and obstruction of the urinary collection system. A renal scan can assess abnormalities in kidney blood flow, tubular function, and the collecting system. A CT scan can identify lesions, masses, obstructions, and vascular anomalies. A renal biopsy is the best method for confirming intrarenal causes of AKI. Having an MRI or magnetic resonance angiography (MRA) study with the contrast media gadolinium is not advised in patients with kidney failure. Giving gadolinium can be potentially fatal. In patients with normal kidney function, contrast media poses minimal risk. In patients with kidney disease, contrast-induced nephropathy (CIN) can occur when contrast media for diagnostic studies causes nephrotoxic injury. In patients with diabetes receiving metformin, the drug should be held for 48 hours prior to and after the use of contrast media to decrease the risk for lactic acidosis. The best way to avoid CIN is to avoid exposure to contrast media by using other diagnostic tests, such as ultrasound. If contrast media must be given to a high-risk patient, the patient needs to have optimal hydration and the lowest possible dose of the contrast agent. Nursing interventions to ensure adequate fluid intake and hydration can decrease the risks associated with contrast media. Other treatment options to prevent CIN are controversial, such as giving bicarb or sodium chloride solutions or prophylactic N-acetylcysteine. Intraprofessional care. Because AKI is potentially reversible, the primary goals of treatment are to eliminate the cause, manage the signs and symptoms, and prevent complications while the kidneys recover. Table 46.4. The first step is to determine if there is adequate intravascular volume and cardiac output to ensure adequate perfusion of the kidneys. Diuretic therapy may be given and usually includes loop diuretics, e.g. furosemide, Lasix, bumetanide, Bumex, or an osmotic diuretic, e.g. mannitol. If AKI is already established, forcing fluids and diuretics will not be effective and may be harmful. Closely monitor fluid intake during the oliguric phase of AKI. The general rule for calculating the fluid restriction is to add all losses for the previous 24 hours, e.g. urine, diarrhea, emesis, blood, plus 600 milliliters for insensible losses, e.g. respiration, diaphoresis. For example, if a patient excreted 300 milliliters of urine on Tuesday with no other losses, the fluid allocation on Wednesday would be 900 milliliters. Hyperkalemia is one of the most serious complications in AKI because it can cause life-threatening dysrhythmias. Therapies used to treat high potassium levels are listed in Table 46.5. Both insulin and sodium bicarb are temporary measures for treating hyperkalemia by promoting a transient shift of potassium into the cells. Potassium will eventually diffuse back into the bloodstream. Calcium gluconate raises the threshold at which dysrhythmias occur, temporarily stabilizing the myocardium. Only sodium polyestrine sulfonate, Kxalate, Patarimer, Valtessa, and dialysis remove potassium from the body. Conservative therapy may be all that is necessary until kidney function improves. If conservative therapy is not effective in treating AKI, then renal replacement therapy is used. Controversy exists about the timing of RRT in AKI. The most common indications for RRT in AKI are 1. Volume overload resulting in compromised cardiac and/or pulmonary status. 2. High serum potassium level. 3. Metabolic acidosis. Serum bicarb level less than 15 milliequivalents per liter. 4. Bun level greater than 120 milligrams per deciliter. 5. Significant change in mental status. And 6. Pericarditis, pericardial effusion, or cardiac tamponade. Although laboratory values provide rough parameters, the best guideline is the clinical status of the patient. Of the several RRT therapy options available, there is no consensus about the best approach. Even though peritoneal dialysis is a viable option for RRT, it is not often used. Intermittent hemodialysis and continuous renal replacement therapy, CRRT, have both been used effectively. CRRT is provided continuously over 24 hours through cannulation of a vein or catheter placement. CRRT has much slower blood flow rates compared with intermittent HD. HD is the method of choice when changes are needed emergently. It's technically more complicated because it requires specialized staff and equipment and vascular access. The patient needs anticoagulation therapy to prevent blood clotting when the blood makes contact with the extracorporeal dialysis circuit. Rapid fluid shifts during HD may cause hypotension. Nutritional therapy. The goal of nutritional management in AKI is to provide adequate calories to prevent catabolism, despite restrictions that prevent electrolyte and fluid problems and azotemia. Nutritional intake must maintain adequate caloric intake, providing 30 to 35 calories per kilogram and 0.8 to 1.0 grams of protein per kilogram of desired body weight to prevent the breakdown of body protein. Adequate energy should primarily be from carbohydrate and fat sources to prevent ketosis from endogenous fat breakdown and gluconeogenesis from muscle protein breakdown. Essential amino acids may be supplemented. Potassium and sodium are regulated per plasma levels. Sodium is restricted as needed to prevent edema, hypertension, and HF. Dietary fat intake is increased so that the patient receives at least 30 to 40% of total calories from fat. Fat emulsion IV infusions given as a nutritional supplement provide a good source of non-protein calories. If a patient cannot maintain adequate oral intake, enteral nutrition is the preferred route for nutritional support. When the GI tract is not functional, parenteral nutrition, PN, is necessary to provide adequate nutrition. The patient treated with PN may need daily HD or CRRT to remove the excess fluid. Concentrated PN formulas are available to minimize fluid volume. Nursing management. Acute kidney injury. Nursing assessment. A number of assessments are essential for developing an interprofessional plan of care. Daily weights, strict intake and output, and vital signs are key. Daily monitoring of a patient's urine output has prognostic implications and is crucial for determining therapy and daily fluid volume replacement. Examine the urine for color, specific gravity, glucose, protein, blood, and sediment. Assess the patient's general appearance, including skin color, edema, neck vein distension, and bruises. If a patient is receiving dialysis, observe the access site for inflammation and exudate. Evaluate the patient's mental status and level of consciousness. Assess the oral mucosa for dryness and inflammation. Auscultate the lungs for crackles and wheezes or decreased breath sounds. Monitor the heart for an S3 gallop, murmurs, or a pericardial friction rub. Assess ECG readings for dysrhythmias. Review all laboratory values and diagnostic test results. Nursing diagnoses. Nursing diagnoses for the patient with AKI include electrolyte imbalance, fluid imbalance, risk for infection, anxiety. Planning. The overall goals are that the patient with AKI will 1. Completely recover without any loss of kidney function, 2. Maintain normal fluid and electrolyte balance, 3. Have decreased anxiety, and 4. Adhere to and understand the need for careful follow-up. Nursing implementation. Health promotion. Prevention and early recognition of AKI are the most important aspects of care. Prevention is directed primarily toward identifying and monitoring high-risk populations, controlling exposure to nephrotoxic drugs and industrial chemicals, and preventing prolonged episodes of hypotension and hypovolemia. In the hospital, factors that increase the risk for developing AKI are pre-existing CKD, older age, massive trauma, major surgical procedures, extensive burns, HF, sepsis, and obstetric complications. Carefully monitor the patient's weight, intake and output, and fluid and electrolyte balance. Assess and record extrarenal losses of fluid from vomiting, diarrhea, hemorrhage, and increase in sensible losses. Prompt replacement of significant fluid losses helps prevent ischemic tubular damage associated with trauma, burns, and extensive surgery. Intake and output records and the patient's weight are valuable indicators of fluid volume status. Aggressive diuretic therapy for the patient with fluid overload from any cause can lead to a reduction in renal blood flow. Monitor kidney function in persons who are taking drugs that are potentially nephrotoxic. Nephrotoxic drugs should be used sparingly in the high-risk patient. When these drugs must be used, they should be given in the smallest effective doses for the shortest possible periods. Caution the patient against abuse of over-the-counter analgesics, especially NSAIDs, as these may worsen kidney function in the patient with mild CKD. Angiotensin-converting enzyme, ACE inhibitors, can decrease perfusion pressure and cause hyperkalemia. If other measures, such as diet modification and diuretics, cannot control the hyperkalemia, ACE inhibitors may have to be reduced or stopped. However, ACE inhibitors are often used to prevent proteinuria and progression of kidney disease, especially in patients with diabetes. Acute care. The patient with AKI is critically ill and may have comorbid diseases or conditions, e.g. diabetes, cardiovascular disease, CVD, in addition to kidney injury. Focus on the patient holistically since they will have many physical and emotional needs. Usually the changes caused by AKI arise suddenly. The patient needs help in understanding that kidney disease may affect the entire body's functions. You have a key role in managing fluid and electrolyte balance during the oliguric and diuretic phases. Observe and record accurate intake and output. Take daily weights with the same scale at the same time each day to detect excessive gains or losses of body fluid. 1 kilogram is equivalent to 1,000 milliliters of fluid. Assess for signs and symptoms of hypervolemia in the oliguric phase or hypovolemia in the diuretic phase. Potassium and sodium problems and other electrolyte imbalances that may occur in AKI. Because infection is the leading cause of death in AKI, meticulous aseptic technique is critical. Protect the patient from those with infectious disease. Be alert for local manifestations of infection, e.g. swelling, redness, pain, as well as systemic manifestations, e.g. fever, malaise, leukocytosis. If a patient with renal failure has an infection, it is important to recognize that the temperature may not always be high. Patients with AKI have a blunted, febrile response to an infection, e.g. pneumonia. If antibiotics are used to treat an infection, the type, frequency, and dosage must be carefully considered because the kidneys are the primary route of excretion for many antibiotics. Dosages may be decreased depending on the patient's level of kidney function if the drug is eliminated by the kidneys. Nephrotoxic drugs should be used judiciously. Perform skin care and take measures to prevent pressure injuries as mobility may be impaired. Mouth care is important to prevent stomatitis, which develops when ammonia made by bacterial breakdown of urea in saliva irritates the mucous membranes. Ambulatory care. Recovery from AKI is highly variable and depends on whether other body systems fail, the patient's general condition and age, and length of the oliguric phase and the severity of nephron damage. Protein and potassium intake are dictated by kidney function. Regular evaluation of kidney function is necessary. Teach the patient the signs and symptoms of recurrent kidney disease. Emphasize measures to prevent the recurrence of AKI. The long-term convalescence of 3 to 12 months may cause psychosocial and financial hardships for the patient, caregiver, and family. Make appropriate referrals for counseling. If the kidneys do not recover, the patient will need to transition to life on chronic dialysis or possible transplantation. Evaluation. The expected outcomes are that the patient with AKI will regain and maintain normal fluid and electrolyte balance, adhere to the treatment regimen, have no complications, have a complete recovery. Gerontologic considerations. Acute kidney injury. The GFR declines with age. In older adults, impaired function of other organ systems from CVD or diabetes can increase the risk for developing AKI. The aging kidney is less able to compensate for changes in fluid volume, solute load, and cardiac output. Although the causes of AKI in older adults are similar to younger adults, they are at increased risk for AKI. Dehydration is a predisposing factor and tends to occur more often in older adults. Dehydration can occur from polypharmacy, diuretics, laxative, drugs that suppress appetite or consciousness, acute febrile illnesses, and immobility. Other common causes of AKI in the older adult include hypotension, diuretic therapy, aminoglycoside therapy, obstructive disorders, e.g. BPH, surgery, infection, and contrast media. Mortality rates are similar for older and younger patients. Patients over 65 years of age are less likely to recover from AKI. Despite this, age is not a barrier to offering RRT. Chronic kidney disease, CKD, involves progressive irreversible loss of kidney function. More than 26 million American adults, or 1 out of every 9, have CKD. CKD is much more common than AKI. We partially attribute the increasing prevalence of CKD to increased risk factors, including an aging population, increased rates of obesity, and increased incidence of diabetes and hypertension. Because the kidneys are highly adaptive, kidney disease is often not recognized until there has been considerable loss of nephrons. Patients with CKD are often asymptomatic, resulting in CKD being underdiagnosed and untreated. It is thought that about 70% of people with CKD are unaware that they have the disease. CKD has many different causes. The leading ones are diabetes, about 50%, and hypertension, about 25%. Less common causes include glomerulonephritis, cystic diseases, and urologic diseases. Kidney diseases are discussed in Chapter 45. Kidney disease improving global outcomes, KDIGO. Clinical practice guidelines define CKD as either the presence of kidney damage or a decreased GFR less than 60 milliliters per minute for longer than 3 months. The stages of CKD are shown in Table 46.7. The last stage of kidney disease, end-stage renal disease, ESRD, occurs when the GFR is less than 15 milliliters per minute. At this point, RRT, dialysis, or transplantation is required to maintain life. Over 500,000 Americans are receiving treatment, dialysis, or transplant, for ESRD. Despite all the technologic advances in life-sustaining treatment with dialysis, patients with ESRD have a high mortality rate. As the stage of kidney disease progresses, mortality rate increases. Mortality rates are as high as 19 to 24% for patients with ESRD on dialysis. Prognosis and course of CKD are highly variable depending on the cause, patient's condition and age, and adequacy of health care follow-up. Some people live normal active lives with kidney disease, while others may rapidly progress to ESRD stage 5. Since 1972, the United States has covered most of the costs of providing dialysis through Medicare benefits. Under Title 18 of the Social Security Act, ESRD was recognized as a disability. Medicare pays for 80% of eligible charges. The state, private insurance, or patients covers the rest. Clinical manifestations. As kidney function deteriorates, all body systems become affected. The manifestations result from retained urea, creatinine, phenols, hormones, electrolytes, and water. Uremia is a syndrome in which kidney function declines to the point that symptoms may develop in multiple body systems. It often occurs when the GFR is 15 milliliters per minute or less. The manifestations of uremia vary among patients depending on the cause of the kidney disease, comorbid conditions, age, and degree of adherence to the prescribed medical regimen. Many patients are tolerant of the changes caused by declining kidney function because they occur gradually. Urinary system. In the early stages of CKD, patients usually do not report any change in urine output. Since diabetes is the primary cause of CKD, polyuria may be present, but not necessarily from kidney disease. As CKD progresses, patients have increasing difficulty with fluid retention and need diuretic therapy. After a period on dialysis, patients may develop anuria. Metabolic disturbances. Waste product accumulation. As the GFR decreases, the BUN and serum creatinine levels increase. The BUN increase is not only from kidney disease, but also protein intake, fever, corticosteroids, and catabolism. For this reason, serum creatinine clearance determinations, calculated GFR, are considered more accurate indicators of kidney function than BUN or creatinine. Significant increases in BUN contribute to nausea, vomiting, lethargy, fatigue, impaired thought processes, and headaches. Altered carbohydrate metabolism. Impaired glucose metabolism resulting from cellular insensitivity to the normal action of insulin causes defective carbohydrate metabolism. Mild to moderate hyperglycemia and hyperinsulinemia may occur. Insulin and glucose metabolism may improve, but not to normal values after starting dialysis. Patients with diabetes who need insulin before starting dialysis may need less insulin therapy when they start dialysis and their kidney disease progresses. Patients with diabetes who develop uremia may need less insulin than before the onset of CKD. Insulin, which depends on the kidneys for excretion, stays in the circulation longer. Insulin dosing may be individualized and glucose levels monitored carefully. Elevated triglycerides. Hyperinsulinemia stimulates hepatic production of triglycerides. Many patients with uremia develop dyslipidemia, with increased very low density lipoproteins, VLDLs, increased low density lipoproteins, LDLs, and decreased high density lipoproteins, HDLs. The altered lipid metabolism is related to decreased levels of the enzyme lipoprotein lipase, which is important in the breakdown of lipoproteins. Most patients with CKD die from CVD. Electrolyte and acid-base imbalances. Potassium. Hyperkalemia is a serious electrolyte disorder associated with CKD. Fatal dysrhythmias can occur when the serum potassium level reaches 7 to 8. Hyperkalemia results from the decreased excretion of potassium by the kidneys, the breakdown of cellular protein, bleeding, and metabolic acidosis. Potassium may come from foods, dietary supplements, drugs, and IV infusions. Sodium. Sodium may be high, normal, or low in kidney disease. Because of impaired sodium excretion, sodium is retained with water. If large quantities of water are retained, dilutional hyponatremia occurs. Sodium retention can contribute to edema, hypertension, and heart failure. Sodium intake is patient-specific, but is generally restricted to 2 grams per day. Calcium and phosphate. Calcium and phosphate changes are discussed in the section on the musculoskeletal system on pages 1068 to 1069. Magnesium. Magnesium is primarily excreted by the kidneys. Hypermagnesemia is generally not a problem unless the patient is ingesting magnesium, e.g., milk of magnesia, magnesium citrate, antacids containing magnesium. Manifestations can include absent reflexes, decreased mental status, dysrhythmias, hypotension, and respiratory failure. Metabolic acidosis. Metabolic acidosis results from the kidney's impaired ability to excrete excess acid and from defective reabsorption and regeneration of bicarbonate. The average adult makes 80 to 90 milliequivalents of acid per day. The acid is normally buffered by bicarbonate. In kidney disease, plasma bicarbonate, which is an indirect measure of acidosis, usually falls to a new steady state at around 16 to 20. The decreased plasma bicarbonate reflects its use in buffering metabolic acids. Bicarbonate level generally does not progress below this level because hydrogen ion production is usually balanced by buffering from demineralization of the bone.